I'm Peter Blanc at ACC.11, and the STICH study has been presented. It's an interesting study, two parts. One part measuring viability and surgical outcomes versus medical therapy, and then the other part, which is just medical therapy versus surgery. And with me is Eric Velasquez from Duke. Eric, you presented the surgical versus medical side of this.
Yeah.
Tell me, I guess the question really is, what did you find? I mean,
Sure.
This is interesting stuff. Cardiomyopathic patients in heart failure, not necessarily terrible heart failure. Should they have surgery? Should they have medicine?
Sure.
What's the right answer?
These patients we haven't had data for on how to guide how we approach these patients before. And so STICH provides that kind of data to help us. I do think the answer can be summed up as, there was an early risk to bypass surgery. Everyone received excellent medical therapy. And then it took about 2 years for that risk to abate. And over time, the benefits of bypass surgery were shown for cardiovascular mortality and deaths or all-cause or cardiovascular hospitalization. The p-value for our primary analysis of intention to treat all-cause mortality was 0.123, so we did not find significance unadjusted. But we knew there would be some baseline variables that differed between groups, and when we adjusted as pre-specified in our protocol, we found a p-value of 0.039 for our primary endpoint. So I think the take-home is CABG should be considered for these patients, but there is an early risk. You should take your time, think through the decision-making, which is quite complex, and then if you have a longer-term horizon and you're as a patient, if you have an expectation that you're going to be around for a while from non-cardiac issues, surgery should be considered strongly.
I guess all of us want to be around as long as possible, isn't that right, Eric?
Right.
But the fact of the matter is that there's comorbidities then that may do you in. Perhaps it's better to think about medical therapy. So tell me how you chose these patients, what actually comprised the two groups. Was there something special that somehow bubbled surgery up to make it better?
Well, these patients all had an ejection fraction of less than 35% and had heart failure symptoms within the last 3 months. And then they had to have coronary disease that you could bypass. They were excluded if they had had recent MI, if they were planning to go for a PCI, or if they had aortic valve disease that suggested they should pursue surgery. So this was a population that really is the bread and butter nowadays of surgical decision-making, where more and more patients with these kind of features are shunted towards surgery and away from percutaneous intervention. But medical therapy has dramatically improved since the trials that first evaluated surgery from the 1970s versus medical therapy, and bypass surgery has improved dramatically as well. I always use one example, which is in the CAST trial, which is what the guidelines quote from the 1970s, where only 25% of the patients at baseline were on aspirin, which we would consider to be terrible medical care now, and only 11% received an internal mammary artery graft. So I think these are real-world patients. Strategies of medicine versus surgery are considered every day, and that's what we compared.
What I'm hearing is that medical therapy is pretty good, number one.
That's
number
true.
two, surgical therapy is pretty good, number two.
Yeah.
And I guess what you're really saying is look carefully at the patients individually and make a decision as best you can on some of the comorbidities.
On the comorbidities, and also I think you have to take into context the patients, the time element. Surgery clearly provides a benefit in terms of cardiovascular mortality and morbidity long-term over out to the 5-year window. But early, there's a risk, as we would anticipate from any intervention.
Yeah.
And that risk needs to be considered. It takes about 2 years. So if you're a patient, first of all, as a patient, you should feel confident having these discussions with your doctors. If you know that you have cancer, which is likely to get in the way of your expectation for a long life, you may want to reconsider someone who's telling you to go directly to bypass surgery. But certainly physicians also should gain a lot of confidence from these data and say, I don't have to board the express train with these patients. I don't have to take them from the cath lab directly to the surgical suite. You can take your time, optimize medical therapy for everybody, and in those patients who are good candidates and feel that other conditions are not going to get in the way, surgery provides a benefit.
Thank you, Eric.
My pleasure.